that's where the money is, really.
I hope so.
So you've done a tremendous amount of work, engaging parents and children, to some degrees, and with social media. I wonder if you, your thoughts about engaging health professionals, because they are the ones who, it's nice that if the parents know how to ask the question, then you can initiate that conversation. But the onus to a certain degree is really in the health professional to do the right thing. So do you have any thoughts on that?
Right. So, I've been part of a couple of teams, one led by Bonnie Stevens at Sick Kids, that have focused, explicitly on knowledge translation strategies to improve pain management practices in health professionals. And we published a paper this year. And it's critically important work. We know that veterinarians get 5 times the training in pain during their training as compared to physicians, right? So, we obviously need to address this at all levels, health professional training programs, clinicians in practice. And I think sometimes it can be more challenging with clinicians who are well established. And certainly when I released our video, I had actually some health professionals call me angry that I was getting their patients to ask about pain management. I have some quotes from comments. They said, I don't want my patients asking about pain management. It takes too much time. And a lot of people saying, I've been giving kids injections for 30 years, and this is a bunch of nonsense, And so I think clearly we also need to address this from a health professional perspective. My involvement in those types of strategies has shown that they're very resource intensive and very expensive. At least the one that we were involved in, a multi-site study at Sick Kids, it had very good results, but the amount of resources that were required essentially involved, getting units within the hospital to kind of set goals for themselves and providing a lot of structure around, okay, in your unit you want to increase sucrose administration for painful procedures in infants. In this unit, you want to make sure that 75% of your kids get their pain assessed regularly. So it was wonderful. It was very customized and really involved, having a clinical champion and getting everybody on board. But it was very intensive and ultimately not sustainable. So it's not that I don't think that we need to engage health professionals in these types of strategies. I think we do, and I think potentially, use of social media may be a way to engage large groups of people. I this summer had the experience of co-hosting a Twitter chat for a nursing group in the UK, over an hour, and the topic of discussion was, why aren't clinical practice guidelines, changing the way we care for patients in pain? So potentially there's, ways that we can reach people, not just parents, but health professionals. But the piece that I'm kind of most interested in right now is that parent piece.
And good. Christine, my question for you, and methodologically, there was one study that I think I would have designed a little differently in the sadness paradigm. Mm-hmm. I think I would have used a broken hammer. I think the bear could have confounded some of the impact of that child, because we use bears. I love bears. Immediately I see that bear with a broken arm and I'm already having a visceral response. Yeah. Why did you choose the bear versus the broken hammer, the lost helium balloon, something for which there would have been perhaps less emotional attachment?
No, that's a good point, and that is something we considered when we went through sort of what possible stimuli we would use, and should we, could we match, was there some way of having the bear hurt the experimenter and just use the bear across the board, or just use the hammer? And in our initial piloting, it didn't seem to work as credibly either way. And so we sort of, and this is a paradigm that has been used quite a lot in the empathy development literature, and people had previously studied both sadness and pain, but not in the same study. So we did end up making the decision, to use a different trigger. But you're right, a teddy bear might promote, more proximity seeking rather than a hammer, for example.
It took me back to my childhood when my doll lost her leg.
Yeah. So that was it's a limitation of the study for sure. Yeah. Evolutionary perspective, we have this instinctive, caring, nurturing instinct, but there's also a protective, stay away, right? That person's been hurt, danger, danger. And so, I mean, this was an experimenter too, engaged in the simulations, and we are just replicating the study now, but with two groups, one where it's an experimenter and one where it's the mother that we've trained to do the simulations. So the mother's actually doing the sadness and pain simulation. But the whole study came about really because if you have young kids and you have the experience of hurting yourself in front of them, like, frequently stub my toe in the bed, and I always saw my kids just sort of like, blank out a little bit when I was hurt, but yet with other types of experiences they wouldn't. So that was sort of where, we got the initial idea was, let's study this, and it just always seemed odd to me. And maybe they're afraid, or there's something about seeing someone in pain that, particularly in a child, you don't have the resources maybe to deal with, or you're trying to figure out what's going on. It's a little bit easier to understand some of the more basic human emotions like happiness and sadness. So, that's a really good point.
Do we have time for
Yes.
more?
Go right
Thank you. Thank you very much to both of you. This is sort of a question that bridges, I think, a little bit of both of your work. You talked about the parent behaviors that might promote pain, and two of those things being empathy and reassurance. Would you say that right now those are acute pain, or do those apply to chronic pain as well?
Right. So, I mean, a lot of my work makes use of, acutely painful procedures or experiences, although we do recruit, children who have chronic pain to take partner studies. But really, what is chronic pain? I mean, it's simply the multiple experience of repeating sort of episodes of acute pain. There are lots of studies that we've done and others have done looking at parent behavior response to pain in more of a chronic context. And certainly the same pattern of results hold, that, any type of overly solicitous, attention-giving behaviors on the part of the parent, are very powerful reinforcers of pain behavior. So when we're working with children who have chronic pain, it's we're often having to work with the families around, it's making that mental shift. It's thinking differently about pain as something that needs to be, treated and solved versus something that needs to be managed in a different way. And often, school is the work of children, and one of our biggest challenges as psychologists working with children with chronic pain is getting children back to school. And frequently parents will say, I'm not sending him back to school until we sort out what is causing his pain. And then we have to say, we're not going to be able to sort out this pain problem until he starts to get back to school. And so, those types of parent behaviors and decisions, there's lots of parallels across both acute and chronic pain.
So with that, and then speaking about catastrophizing, and one of the techniques to be validating the patient or client, how do you, I guess, draw that fine line with trying to validate somebody but doing it without too much empathy or too much reassurance?
Well, and I think that's the sort of how you frame it too to families that makes a difference. And it's hard to say, well, don't give your child who has chronic pain attention. I mean, that's not what we're saying. But it's like, how can we, I guess, pull that together in a way that is going to help support what the increased goals are around functioning. And so, one of the most critical things that we do clinically when we're working with children who have pain is help to get families on board with a conceptualization of how pain works. And we always use the idea of, the analogy I use is it's a car alarm. And pain is normally your body's alarm system to tell you that something is wrong. But and just like a car alarm can go off for no reason, and kids can always say, oh, I see car alarms going off all the time, because they're oversensitive or whatever. Your body's alarm system is too sensitive. And while the doctors might be trying to figure out, they've ruled out all the sort of major reasons why it would be doing that, but they're still going to be working on that if that's indeed, where they're at. But we need to figure out how to turn this alarm down so it's not going to interfere with your life so much. And then parents can usually kind of make the shift in their thinking around how they need to approach this problem. And we do provide some strategies, like we're not saying you can't ever talk to your child about their pain, but we don't want it to be, in many families we work with, it's the only thing they talk about with their children. It's how they start the day, it's how they end the day, it's what they text about during the day. And so we just sort of say it's fine to check in with your child. When do you think the most important time to check in it is? Okay, so then you can have a 5-minute pain chat, at the beginning of the day or the end of the day, but it's no more than 5 minutes, and that's it. And changing some of the contingencies up there so that we don't want children to feel that they're not appreciated or validated or their experience. I mean, whether you have chronic pain or an amputee, that's horrible. I mean, you shouldn't have to have this happen. But on the other hand, this is your reality, and we have to figure out how to increase your functioning as much as possible. So, yeah. Thank you.
Let me ask one more time at the remote site, Diamond Center, any questions?
No, thank you. Thanks very much.
Great. And CSB?
That was great. Thank you very much.
So that's wonderful. So
Thank you.
With that, I want to thank you again for Christine and Michael. It's really fantastic talk. You really pushed our boundary to think about pain differently. Using social media and redefining rehab disciplines. Yes. This is fantastic. So I hope that you have a nice visit at UBC.
Sorry about the weather.
Quite a number of activities.
It was nice last week.
So that's wonderful. So thank you again.
Thank you for having us.
Thank you.